All right, is everyone ready to begin?
Happy baby.
All right, let's get started. Sorry for the late start, but I guess it was good. I showed up a few minutes later than I wanted to, but the door was locked anyway, so none of us could get in, so we're all together. Anyway, any questions from last week? We finished up the first part of cardio, correct? You can see the second part is uploaded. Nothing else. Let's hit the ground running for this stuff then. So we're going to be talking about the majority of our antihypertensives. You'll find that a lot of these medications here do not simply work only as antihypertensives. You're going to see these used for a lot of different things. So for instance, diuretics could probably be used for what else? Edema, right? If you want to get rid of extra fluid, diuretics are going to be really good at that, right? So we'll talk about the different classes, how they work together, how they may work differently from one another, different sort of side effects you're going to see with these. And you'll find a lot of these classes as we get into talking about different subjects. Say, for instance, we talk about CHF. Well, guess what? A lot of the beta blockers and the diuretics and ACE inhibitors, all the stuff we're going to talk about in this lecture are going to show up there as well. We're going to talk about how we use them differently in those different disease states. But if you know how they work now, and their mechanisms, interactions, you're golden. Like you already know 90% of what you need to know about these drugs. So anyway, so what did diuretics do? How do they get rid of fluid? Do they just like perspire it out of your skin? You pee more, right? Yeah, so they make you pee. So how do they do that? Anyone know? That's one way to do it. Yeah, so we'll see. So what does antidiuretic hormone do in the kidneys? Oh, interesting. Okay, so good. So we're going to get into all those details, right? So we're going to talk about the different parts of the nephron. We'll talk about where the diuretics work, what they block. You're absolutely right. They block things usually from being reabsorbed. We'll look at what those are. A general rule of thumb is wherever salt goes, and when I say salt, mainly talking about sodium, wherever salt goes, what follows it? Water wants to follow. So if you inhibit salt reabsorption in the kidneys, water follows it, right? That means that's how you get rid of that extra fluid there. Obviously, we know we want to keep a balance between not having too much or too little, because that can lead to problems either way, right? You can get hypotension, cardiovascular collapse, too little fluid, too much, you get edema, you can develop that, pitting out in the extremities and the lungs. Not great. So we want to keep a balance between these two here. Now the kidneys are very complicated. Even though they're quite small, they do receive a lot of oxygen because they have a lot of pumps and different things like that. They're all working to make sure that everything that they're filtering, they're reabsorbing the right amounts, excreting the right amounts to make sure they keep everything in check. And they have a lot of compensatory mechanisms built into them to make sure that they keep the right amount of blood flowing to them and they keep the pressure appropriate for them. Now, have you covered like renal physiology at all? We'll cover the basics again, right? So you probably at least had an A&P, correct? Maybe at least talked about it like in previous physio classes you've been through. So we'll cover this again. But anyway, one of the big things we're going to be seeing here is the renin-angiotensin-aldosterone system. Have you heard of this system? The RAS system. This is going to be a very prominent sort of thing here we're going to be talking about in terms of diuretics. We're talking about antihypertensives, etc. So when I say renin-angiotensin-aldosterone system, what are the kinds of primary components there? Renin, right, which stimulates what? Angiotensin 2 production, and that also stimulates aldosterone. Perfect. So you got three of the big components already down right away. Perfect. And so oftentimes what you're going to find is that when the kidneys detect that there's not enough pressure, there's not enough salt being filtered, there's not enough volume, they will then activate this reflex mechanism, okay? Because they want to help to regulate to make sure they get just enough blood flow to get our filtration up, right? What do you call that filtration rate? GFR, glomerular filtration rate. And so they can regulate that through things like the autonomic nervous system, sympathetic nervous system, the RAS system. We'll see how all this plays a role in here, right? So things like atrial natriuretic peptide, things like ADH or antidiuretic hormone all play a big role here, okay? So we're going to see how we can interfere with all these different substances. So again, the main thing that we're going to be talking about here is the nephron, right? We're going to talk about the different components here. In terms of filtration, we're also going to see that blood flow is going to be coming into the glomerulus and exiting out, and we'll talk a lot about the efferent and the afferent arteriole. When I say afferent arteriole, does that mean blood's coming in or out of the glomerulus? The afferent. In. Afferent is going to be coming in, efferent will be heading out. This is a big place where we're going to have a lot of regulation of glomerular filtration rate, right? This is where we're going to regulate how much blood's coming in and how much pressure that blood's going to be forced to work against to get out of that glomerulus, okay? We'll talk about different substances that are going to have a big effect on that, right? So then things are going to get filtered here. They're going to go into the proximal convoluted tubule. They'll go through the loop of Henle, right? It's actually named after the Eagles singer. Anyone? No? Okay, well, never mind. Some of you might be too young for that reference, but that's okay. And then we'll go through the distal convoluted tubule, finally to the collecting duct, and then everything kind of pools together and eventually leads out as urine, right? So we're going to see that each of these steps here, there's going to be a place for the diuretics to interact with and affect things like sodium reabsorption, potassium, calcium, all kinds of different ions. And so what you tend to find is that we have a lot of things that get filtered through the glomerulus, right? And that's going to be affected by the pressure there in the glomerulus. Higher pressure means more filtration that occurs, higher GFR potentially. And so you're going to see that things like glucose are going to be filtered out. You're going to see that things like bicarb, sodium, all of your ions get filtered out. Amino acids, even proteins, get filtered out. Now, does that mean that you pee all of those things out? Anything that gets filtered, you pee out? No, there's a lot of reabsorption that occurs there, which is important because if that didn't happen, we'd be in big trouble, right? So, but we can exhaust these mechanisms, right? What happens with a diabetic patient whose blood sugar is like 500? Can they filter and reabsorb all of that glucose back? No, where does it end up? In the urine, right? So when you do a UA, you see that, yeah, they have glucose there. Normally we should be able to reabsorb all of that, but we can exhaust these processes here. Anyway, so we're going to be filtering a ton of plasma, getting rid of all of its kind of waste products and things like that, and then we'll see how they get reabsorbed later on. So starting with a proximal tubule, you can see that the majority of reabsorption happens here. Like almost all of your glucose, all of your amino acids get reabsorbed here. This is where things like sodium and bicarb get reabsorbed. Different ions will be absorbed here. This is also where drugs can either be reabsorbed or excreted, as it turns out. So not only can you have certain drugs that maybe they don't even get filtered at the glomerulus, but they can also be excreted out into the renal tubule at this spot here, right? So that's one thing to consider as we talk about drug reabsorption or excretion. That the proximal tubule is the big place where this occurs here. Going down to the loop of Henle, what is really the responsibility for the loop of Henle?
It's just water, like exchange with
So yeah, so water exchange, we're going to see that when you're coming down the loop of Henle initially, you're going to see that this is permeable to water. So you're going to see that water is going to be able to flow in or out of the tubule here. The big thing to note though is as you go into the ascending loop, that's that thick part of the loop of Henle, you're going to see it's only going to be permeable to sodium through a lot of sodium pumps. The point here is that you have a lot of sodium that gets trapped in this part of the nephron such that water wants to follow all of that out. This is the main way that we're going to help to concentrate the urine. So if you mess up with the loop of Henle and if you can't concentrate that urine effectively, what would happen? If you can't reabsorb all that salt, all that water stays in the tubule, and guess what it comes out as? Urine, right? So you're going to see that this is a big spot. This is probably one of the most important places where our diuretics can work in terms of getting out the most fluid, right? Something to keep in mind. We'll talk about that a little bit later. But again, obviously, things like your loop diuretics are going to work in the loop of Henle. We'll talk about those specifically. Next up, we have the distal convoluted tubule. This will be another spot where some of our diuretics are going to work, namely the thiazide diuretics. This will be an important point here. You're going to see that sometimes we can even use diuretics in conjunction with one another to work better, because sometimes you'll see that I can give a loop diuretic to a patient and they may have compensatory mechanisms to where if they can't reabsorb all that salt in the loop, they may try to reabsorb more salt in the distal convoluted tubule. So sometimes by giving two diuretics that work in different portions, they can work better together, right? So you can see synergy sometimes there. But this is where you're going to see also that some degree of water control is going to happen through aldosterone, but really the collecting duct is where you're going to see the majority of things like aldosterone and ADH are going to be playing a big role. We'll talk about their specific activities a little bit later on because it's important to understand the distinction between aldosterone's effects and then antidiuretic hormones effects. Okay, we'll talk about what those are. Okay, so getting into our initial drugs here, I'm sorry if my pictures are covering up anything, but we have the loop diuretics. So obviously you know they're going to work where? Henle, very good. We have 4 drugs here. I'm just going to move this over some. Sometimes my formatting gets a little off. We're going to have 4 drugs that fit into this category. We're going to have furosemide, we're going to have bumetanide, torsemide, and then ethacrynic acid, because that one wants to be a little different and not follow the naming conventions. But I'm sure everyone's heard of Lasix before, right? Anyone know where the name Lasix comes from? It lasts about 6 hours. So if you ever see QID dosing for Lasix. That's where the name comes from, essentially, is because it lasts about 6 hours. So anyway, a little bit of trivia there for you. So what's going to happen in these pictures here, basically they're going to be oriented such that this is going to be the urine side, the luminal side of the renal tubule. Here's going to be the interstitium, or where the blood's going to be reabsorbing stuff. And then here's the thick ascending limb of the loop of Henle. Essentially what normally would happen is you would have sodium, potassium, chloride being reabsorbed to this transporter here, and then it would then be reabsorbed into the blood. Water is going to follow along with that, but if I block this transporter, if I stop this from working, guess where all that salt stays? In the luminal side, and then it's going to be excreted out in the urine. So does that mean only sodium is getting left out in the lumen? So potassium is going to be left out in the lumen. And also because you're monkeying up with this transporter here, you're also going to see things like magnesium and calcium also stay out here as well. So what sort of side effects might you expect to see with that? Maybe it could affect heart rate potentially, but what are more specifically due to the ion effects? Low levels of hypokalemia, hyponatremia, hypomagnesemia, hypocalcemia. These are all things that can occur because you're blocking reabsorption of those ions in the renal tubule, right? So you just pee them out, and thus they can develop low levels of that, which can be important for your cardiac patients, right? Because potassium is a really important ion that helps regulate cardiac conduction, magnesium, sodium, all these are really important ions there. So this is important. One of the biggest side effects you'll see with these patients is they're going to get hypokalemic along with all these other electrolyte disturbances, okay? But they are extremely good at what they do, and if you want to get fluid off of a patient fast, probably the only other most efficient way would be dialysis, but that's pretty labor intensive. This is the best way to do it, right? You give a dose of Lasix, you can get pounds of fluid off very quickly from those patients there because you decrease how much sodium is being reabsorbed by a pretty significant margin there, okay? But again, biggest thing to know is what kind of side effects would you expect to see from these drugs? Hypomagnesemia, hypocalcemia, hypokalemia, all would be expected with this. Hypovolemia, right? Because you're losing fluid, and that could lead to that increased heart rate because you're trying to pump it, trying to compensate for that decrease in blood pressure, right? So we see all these mechanisms happening here. Other things that can occur, some of these are reflex mechanisms that occur due to changes in the kidney function itself. So for instance, like hyperglycemia. So things like having low potassium levels can impair insulin release. Less insulin being released does what your blood sugar? It's going to go up because it stays just there in the bloodstream, right? Also, what you're going to notice is that when the kidneys start to detect, hey, there's low volume here, they're going to say we need to kind of increase the blood pressure. We need to go ahead and increase things like the renin-angiotensin system. They'll also increase the sympathetic nervous system as well. So you can see things like decreasing insulin release and also increasing glycogenolysis, right, due to beta-2 effects. The glycogenolysis is what? It's in the liver, where you break down glycogen and then you undergo, what's the next step in the process? To make new glucose. Gluconeogenesis, right? So you'll break down glycogen to produce new glucose. That's part of that process there as well, right? So you're going to see these kind of secondary effects that occur, due to the medications that we're putting into the system here, okay? Also note you can have some systemic vasodilator actions. This is going to be something where they may have some additional benefit on blood pressure, but typically what you find is with the loop diuretics, even though you can acutely get a drop in your blood pressure because you're losing that volume, the kidneys usually compensate with that renin system such that these are not great as antihypertensive drugs, not for the long term. But if you want to get rid of fluid, these are really good drugs for that. And so, like as I mentioned, that reflex activity, due to volume depletion, you're going to get more aldosterone being released, you're going to get more antidiuretic hormone, more renin is going to be released there, all due to that effect, okay? Also note that patients, say for instance with gout, are going to have issues with this as well because this can actually increase uric acid levels. For one, you can see that you're going to have more proximal convoluted tubule reabsorption, so that's one thing that can increase gout levels. But also what happens as your blood volume decreases, as you lose that fluid, what happens to the uric acid you already have in the system? Gets more concentrated, right? So in that case there, it can also predispose someone for precipitating out those renal, that uric acid, and that can be a problem for which kind of patients? History of gout, right? So they could have a history of like a patient starts a loop diuretic for CHF and all of a sudden their great toe starts hurting, right? Could be related to a gouty exacerbation due to the fact that uric acid is more concentrated, okay? So other things you can see with a lot of diuretics, you're going to have a mild metabolic alkalosis. This is due to what we call a contraction alkalosis, or basically the bicarb in the blood gets more concentrated. Also, you're going to find that you're going to be secreting more hydrogen ions, into the urine, which leads to that mild alkalosis, right? So maybe your bicarb levels are going to look a little higher in those cases there. What's a normal pH in the serum? Yeah, 7.35 to 7.45. So maybe you get something a little bit above that, maybe 7.5, maybe something like that. Pretty mild effects here. Other things you can see, maybe due to increased sympathetic effects, you can find that maybe your triglycerides start to go up a little bit. It'd be another sort of feedback sort of effect there. And one thing to note with these medications here, the loop diuretics, is that they still stay effective even in patients have low creatinine clearances. So even if you have a patient with poor kidney function and say their creatinine clearance is at less than 30, these will still work to help get rid of fluid. Okay. Now what's a normal creatinine clearance? About 30? You're getting closer. It's kind of like Price is Right. You want to keep guessing higher and higher, but not go over. So 31. No. Usually around 100 or so, right? So as long as you're getting, somewhere around 100, that's usually considered pretty normal. Once you start to get well below that, it's where we start to consider kidney impairment is playing a role here. Less than 30 is usually pretty severe, okay? So even if they have poor kidney function, loop diuretics are still going to be effective in helping to get rid of some of that fluid, okay? So that's one thing you want to note with that. Now, what do we use these drugs for? Again, loop diuretics are good for getting fluid off of the system. So things like pulmonary edema, that's going to help get rid of that fluid, right? Things like nephrotic syndrome, or maybe that protein loss and they can't really regulate their plasma fluids. This can be useful helping get rid of that fluid too. Ascites, heart failure, renal failure, hypertension, maybe in the acute sense. Maybe they're really volume overloaded, this can help with that. But again, the hypertensive effects are going to be fairly short-lived for these drugs here. But if you got too much fluid on the system, a loop diuretic is going to help get rid of that, okay? That's probably going to be the main thing. We'll talk about CHF later and how patients will use that. They can do things like monitoring their weight day to day, and if they notice they're going up by a couple pounds over the course of a week, they can take a loop diuretic to get rid of that extra fluid, right? So sometimes these drugs are like an as-needed sort of basis. Now, what are the adverse effects we can find? We already talked about a few of these, but certainly volume depletion, right? If the body detects there's low volume, things like heart rate's going to go up, so you get like a reflex tachycardia. You're going to have that renin-angiotensin system is going to get upregulated, so that's going to cause some vasoconstriction, hypokalemia, hyperglycemia. All this makes sense based off what we've already talked about. Also, some notable things here include things like ototoxicity. So you can end up having some damage to the hair cells in the cochlea, which can lead to some issues there. Hyponatremia, in really severe cases, can cause seizures, right? Because that helps to regulate how our neurons are actually firing. If you have low sodium, that can be a problem. And just note, some patients may have allergic reactions, but of course that's a risk with really any medication, right? So those are the big side effects you'd be worried about with the loop diuretics. Now, what kind of drug interactions are we going to see here? So a couple of things you're going to find is that NSAIDs, what are some examples of NSAIDs we talked about? Ibuprofen, naproxen, there's a lot of other ones we'll get to in later sections, but those are the main over-the-counter ones we've talked about. They blunt the natriuretic. When I say natriuretic, what does that mean? It's a good medical term for excrete sodium. You pee out sodium essentially, right? You're going to see that NSAIDs actually blunt that response, and I'll tell you why that actually occurs. And so this will be an important side effect. And when you think about NSAIDs, one of the things they warn patients about is it can cause kidney failure. They can cause kidney injury. Have you ever heard of that? The reason for that is, let me kind of draw this out. And again, my art skills are not great, but you can at least work with me here, right? So let's go ahead and assume we have a glomerulus, and this may look kind of like a uterus with some fallopian tubes, but bear with me, this is a glomerulus. And let's say that this is the glomerulus right here. We have blood flow coming in, so this is the afferent arteriole. We have blood flow coming out, which is the efferent arteriole. And here's your glomerulus, and here's the renal tubule, okay? Make sense? So you have to have sufficient pressure here in the glomerulus to cause that fluid to actually get filtered through. If there's no pressure, then nothing gets filtered, okay? So one of the things to note here is that one, you want sufficient blood flow coming in through the afferent arteriole in order to allow that pressure to build up, right? So one of the things you're going to find is that prostaglandins are very important vasodilators at the afferent arteriole, okay? So this prostaglandins will keep these open, which allows for blood flow to come in, which allows for filtration to occur. Well, what would happen if I gave a drug that got rid of prostaglandins? You cause vasoconstriction of the afferent arteriole, and what does that do to your GFR? It's going to go down. It's like pinching off a hose, and now you don't have any flow coming through. Okay? Now, what drugs have we talked about that decrease prostaglandin synthesis? NSAIDs, right? So this is why you worry about, especially patients who have existing kidney injury, or like, say, chronic kidney disease. Giving them an NSAID can acutely decrease their GFR. You can cause acute kidney injury by giving them an NSAID. Does that make sense? So losing those prostaglandins causes vasoconstriction on that afferent arteriole, and that decreases GFR. All right, that's an important drug interaction. I'll come up with several of these here, but also you find that NSAIDs will kind of blunt that effect, because if I am decreasing flow coming into the glomerulus, you also are going to decrease the amount of sodium that you can filter, and thus you're decreasing that natriuretic effect, right? And that's going to help to blunt your blood pressure response as well. So that's why they have that interaction there. And frequently NSAIDs are going to have a negative effect when adding them on with other antihypertensives. Okay, it's kind of a blanket thing. We'll talk more about that as we go forward. Okay, how about like aminoglycosides? What drugs go into that class? Gentamicin, tobramycin, amikacin, right? They can also potentiate that ototoxicity. So imagine a patient who is in the ICU and they're volume overloaded and they have a pneumonia. You're giving them, gentamicin and Lasix to get rid of that fluid. Maybe they're on vancomycin too, because you're covering for MRSA, right? All those things can potentiate that ototoxicity, and they may not be able to articulate that, hey, my hearing is going, because they're intubated or something, right? Those are things to note. Things like lithium can be a problem here as well, because using lithium along with a loop diuretic can decrease clearance of that lithium, lead to toxicity. We'll talk about that next semester for sure. And then digoxin or digitalis we'll talk much more about in a few upcoming section when we talk about heart failure. So just kind of keep that in the back of your mind. But that's going to be an antiarrhythmic that we'll use in some of these patients with that AFib or THF. Okay, those are the loop diuretics, right? So you have furosemide, bumetanide, torsemide, and ethacrenic acid. Now we're moving into our thiazide diuretics, okay? Of course, not all of these are going to follow the same naming convention either, but it is what it is, right? So we have chlorothiazide, we have hydrochlorothiazide. What does that get abbreviated to? HCTZ, right? One time when I was doing a community rotation when I was in school, I had a patient came up, an older gentleman. He said, "I'm here to get a refill for my Huctaz." Huctaz. Huctaz. What is Huctaz? And so he spelled it out for me. It's HCTZ. So sometimes communication can be a little difficult, right? But that's how you always called it. Anyway, other agents include things like chlorthalidone, metolazone, and dapamide. These are kind of your common ones that you're going to be running into in terms of thiazide diuretics. So these are going to be working in the distal convoluted tubule here. Let me move this out of the way too. These are going to be working in the distal convoluted tubule to inhibit sodium and water reabsorption. So a different transporter this is going to be working on. And again, so we've already gone through the loop of Henle. Now we're in the distal convoluted tubule. Basically what you're going to be doing is blocking the activity of this transporter here. So you're going to have less sodium and less chloride being reabsorbed. Now overall, you're going to find that the thiazides are going to be less effective in terms of getting rid of volume. They're not going to be nearly as potent, right? The loop diuretics are the most potent at getting rid of volume. This is not going to be the case here. They're a little bit more mild in terms of their activity, which makes sense because we saw that most of the sodium reabsorption happened in that loop of Henle. So by nature, these are going to be a little less effective in that case there. So a big thing here is they're blocking that, and you're actually going to find that you'll still lose some magnesium, you're still going to lose some potassium. One notable difference with these is that actually you're going to absorb more calcium, okay? So this can lead to things like hypercalcemia. But it could also be beneficial if you had a patient, like what kind of patients would have calcium, say for instance, hanging out in the urinary system, causing, say for instance, stones, right? So patients with a history of kidney stones or nephrolithiasis, this could actually be something that can help with that, because you're keeping less calcium in the urine, because it helps to promote reabsorption of calcium. I'll mention that in a second, but again, it's good to know how the electrolyte changes are going to be different amongst these different classes of medications, right? So if I give you, say for instance, on a test, and I say a patient has a potassium level of 2.8 and a normal is what? Yeah. And I'll give you reference ranges on the test, right? So you should be able to identify if the level's low or not based off comparing it to the reference range. But just for your edification, what's a normal potassium? 3.5 to 5, right? So if I say a patient's level is 2.8, you'd say that's low. So which one of these drugs would be contraindicated in that patient? And one of those might be a loop diuretic, right? That could be a problem, right? It might be a thiazide diuretic. That would also be a problem because you're going to get rid of more potassium in that case. And you'll also see that some drugs can actually increase potassium levels, and I may give you the opposite problem on the test. They say patient's potassium level is 6, with a normal of 3.5 to 5. Which one of these would be contraindicated, okay? So you have to be able to identify those. What kind of changes are these causing in electrolytes? Because again, a quick way to kill somebody is to monkey around with their potassium, okay? Cause significant arrhythmias, either too low or too high, and so that's why I like to harp on that sort of thing there. Sodium as well, right? It can cause seizures, it can cause all kinds of problems.
I had a patient yesterday at ICU, and there was a patient whose potassium was 8.
Mm-hmm. Anyway.
Heart attack.
Yep. Yeah, so it's a quick way to go into VTAC, VFib for sure, right? So that can be very problematic there. So yeah, potassium 8, no good. However, what's an important thing to know? So say, like, for instance, you have like a healthy patient and you get a blood draw on that patient, and then it comes back and potassium looks like very high, which is abnormal. The patient's not having really any problems. It was a routine lab draw. Hemolysis, yeah, it's an important thing to consider as well. Make sure that the lab test is actually done correctly. Sometimes when you're doing those lab draws, the red blood cells can actually lyse open, and that can allow for potassium to leak out. And that can cause the potassium levels to look falsely high. And usually the labs will mention that. They'll say, hey, hemolysis detected on this. So that's a good thing to note there as well. Okay. Anyway, that patient's potassium probably was accurate, and yeah, not great. So anywho, so here again, we're going to see decreases in absorption of sodium, decreases in absorption of potassium. So magnesium is going to be affected as well, but calcium is still going to get reabsorbed. Okay. And so again, you're going to see maybe it increases urine output by maybe 1 to 2 liters or so, not nearly as severe as the loop diuretics, but still pretty okay. And as I mentioned, they're going to see more calcium reabsorption. So you're going to decrease excretion because now you're reabsorbing more of it. And that's going to be good, maybe not for a patient with hypercalcemia, but certainly for a patient who maybe has a history of kidney stones. And one thing you'll note here in Florida, especially people who are transplants into the state, our tap water has high levels of calcium in it, right? So again, some people will develop kidney stones here as a new problem because they're not used to the kind of water that we have here. So one thing to note, right? Not everyone, but some people do. You're going to see similar reactivities here. Oh, yes, ma'am.
So the question example you gave the patient was hypokalemic, and you said you contraindication would be loop diuretics. Wouldn't thiazide diuretics also be?
I could have put that as an answer choice as well. Yep. Yeah, I'm just trying to give you an example of how I could put that on there for sure. Okay, so some other actions, you're going to see a similar side effect profile to the loop diuretics, usually just less severe, so like less severe in terms of accumulating uric acid, less severe in terms of the hyperglycemia, but still somewhat mild there. Also, just note, by decreasing blood volume, you can decrease that GFR acutely. So, as I mentioned, that afferent arterial, if you just have less blood there to be filtered through, then that will decrease GFR as well, right? So loops can do the same thing. Where do we use our thiazides? Well, hypertension is going to be the #1 indication for your thiazide diuretics, okay? Sometimes we can use it to increase urine flow for renal patients, not super common. Anything else we can try to get rid of that some extra fluid, that can be used here. And as I mentioned, the hypercalcemia, renal calcium stones, that's going to be useful for the thiazide diuretics as well. Again, help to reabsorb calcium such that they don't cause those stones to occur. Anyway, so let's talk about hypertension here, because I want to focus on this since, again, is this a common occurrence in the patients you're going to see out there? Like the majority of them probably will be somewhat hypertensive. So you tend to find that the thiazide diuretics work best in patients who are more elderly, obese. We see that also black patients are going to be pretty well affected by this, and anyone who's in what we call a sodium retentive state. And so basically what you're going to see is when you introduce a thiazide diuretic into these patients, several things are going to occur. In the short term, you're going to get decreased blood volume, which will decrease pressure acutely. However, that's short-lived because the renin-angiotensin system is going to get upregulated in those cases, and that causes the pressure to go back up. Not great from that standpoint. What you are going to find, though, is that the thiazide diuretics chronically are going to help to decrease what we call this water logging that occurs in the vessels, right? So if you imagine your blood vessels over time, as they accumulate, I think I'm going to do some more drawing here just to keep you guys somewhat interested, right? So imagine you have a blood vessel here. Imagine you have the endothelial lining. Let's say all of a sudden we start to accumulate over the long term a bunch of salt in the endothelial lining. What do you think happens to water? Water's going to want to go into there, right? So actually what you end up finding is that over time, those endothelial walls tend to thicken, right? So the diameter gets smaller, and so what does that do to your pressure, you think? It increases, right? What happens if I get rid of that salt? Water goes along with it, and it relaxes more. You're going to find that the diameter is going to get bigger. That allows for better flow through, right? So because of that, that's how we chronically are going to have thiazide diuretics help with blood pressure, right? They're going to help to get the blood pressure under control. And these are oftentimes, for a lot of patients, going to be a first-line therapy, right? Or at the very least, an add-on therapy. It's going to be very beneficial in terms of synergy there, okay? So also, you're going to find that you're going to have some decreased vascular responsiveness to norepi. We know norepi is a big cause for causing vasoconstriction through that sympathetic nervous system. All these things are going to be really good. And also, overall, you're going to find that very low side effects, right? You're giving like 25, 50 milligrams of HCTZ. You're going to find some acute diuretic effects initially, but it's going to go away pretty quickly due to the compensatory mechanisms. But they're really good in terms of keeping that blood pressure under control, and then again, not a ton of side effects. So nice from that standpoint. So anywho, so again, what you will find in terms of sort of reflex mechanisms in terms of adverse effects, you're going to find here that yes, the renin-angiotensin system is going to be upregulated, which is why we frequently will see agents that work on that system along with something like HCTZ because they work really well in concert with one another. But certainly things like hypokalemia, gout, metabolic alkalosis, all that can occur just like with the loops. Again, hypercalcemia would be one thing you can see with this. So if I had a patient who had a calcium level, let's say of 11, let's say like 8.5 to 10 maybe is like a normal calcium. They had a level 12, maybe a thiazide might not be a good option for them. Okay. Who might have like high calcium levels? What kind of patient? Maybe they're eating a ton of Tums, maybe. Hyperparathyroidism is a common one, right? So again, if they're causing a lot of calcium to be leached from the bones because they have high parathyroid levels, parathyroid hormone levels. Anyway, we'll talk about that later. But main point being is that be careful in patients who have hypercalcemia. This could worsen that, as we already mentioned. Again, you can see some photosensitivity, so that's one thing to note with these agents here. And of course, dizziness, headaches, weakness, a lot of that is related to either electrolyte imbalances or just kind of low blood volume overall. One thing I will note here with a lot of the antihypertensives, a lot of them can cause sexual dysfunction, right? Which can be problematic for some of your patients, right? Because they probably don't want to start a new medication that makes them unable to perform, right? So in these cases here, we have to kind of choose which medication might be best for your patient. Now, why do you think this could cause sexual dysfunction?
Decreasing blood pressure, which is decreasing blood pressure volume.
So less pressure, less volume can make it more difficult to achieve an erection, right? So that's one of those things you're going to find there by decreasing that blood volume that can be an acute problem for those patients, okay? Sir?
So it's indicated for hypercalcemia, but also adverse effect is hypercalcemia?
Uh-huh. Seems counterintuitive, isn't it? So again, if a patient just had hypercalcemia and that was their only problem, I would not want to use something like HCTZ. But what if they were having kidney stones as a result of the hypercalcemia, right? They had enough calcium that was being filtered through the glomerulus and actually precipitating out, either in the renal tubules or the collecting duct or somewhere along the urinary system. They had enough that was precipitating out. Then you could use a low-dose thiazide diuretic to try to help reabsorb some of that calcium. Even though it will cause a mild increase in their serum calcium, as long as that's not causing too many other problems, then you help to prevent those stones from forming there. So again, it may not be the best way in order to manage it, but that is one thing that you could do.
You might have already said this, but why, if you have hypercalcemia, why are you taking something that reabsorbs calcium?
So that would be in the case of the stones, right? So again, if they were at risk for developing that nephrolithiasis or that history of it, of recurrent nephrolithiasis, you want to prevent that from occurring, that's where a low dose thiazide could be useful there. Again, you're weighing the risk versus the benefit. So all of a sudden, if they're getting more symptoms from the hypercalcemia, then it may not be a good risk-benefit sort of trade-off there, right? So again, it's all going to be very on a patient-by-patient basis there. Usually, things like potassium, you don't have a high tolerance for, like large shifts in levels. Calcium, though, some people have high levels of calcium. It's usually not that big of a problem. It just depends on how symptomatic they tend to be, okay? Anyway, constipation is going to be another big thing. Typically, high calcium levels tend to kind of slow down peristalsis, so that could be another issue you run into there. And then this is an important point to note here, is that thiazides tend to lose efficacy once you get down to low creatinine clearances, so less than, say, 30 to 40 mLs a minute. They tend to be less effective. The one exception to that is actually metolazone. I'll never forget metolazone because I remember one time I was dealing with a patient in the ER that had kidney injury and the creatinine clearance was like 15 or something like that, but they're very edematous and they wanted some help getting it off. The loops were doing their thing, but they were having some loop resistance, which is a problem you run into with chronic diuretic use. And so the nephrologist was coming down, helping out, and he was like, let's go ahead and use metolazone. And I was like, well, metolazone, the patient has renal dysfunction. He said, no, metolazone still remains effective, and it remains so effective that it can make a rock pee. So always remember that. It's like, oh, it can make a stone urinate. It's like, okay, that's going to be a pretty good diuretic. So that's how I always think about thiazides. Because again, do rocks even have kidneys? No, but if it can make them pee, then it should be able to make your patient pee, right? Anyway, that's always the analogy I've always kept in my head. Maybe it'll remain in your head as well. Anyway, as I mentioned, you're going to see similar drug interactions as with the other loop diuretics we've already talked about, things like NSAIDs, digoxin toxicity. All that is related back to either effects on the afferent arteriole in the case of NSAIDs or electrolyte disturbances causing issues like antiarrhythmics like digoxin. Okay, so now we're moving further into the renal tubule. Now you notice we skipped the proximal convoluted tubule entirely, right? Now in terms of efficacy, we saw that the loop is going to be the most important in terms of getting rid of volume. We saw the distal going to be less so. How good do you think our diuretics would work if they worked at the proximal convoluted tubule? They're going to be pretty wimpy because if you think about it, they have to get all the way through the loop diuretic too, all that volume, and that can be reabsorbed there. So we'll talk about that towards the end, but those are going to kind of be the wimpiest ones that work at the proximal. Now we're going to be getting into the potassium-sparing diuretics, and these are going to be working mainly in the collecting ducts, okay? Sort of like very, very distal into the distal convoluted tubule into the collecting ducts is where these are going to work. And essentially what these are going to do is they're going to be blocking these luminal sodium channels. Yeah, these sodium channels that are here, and these are going to be directly blocking them, okay? And so what that's going to do downstream of that is also inhibit the sodium-calcium antiporter along with this hydrogen antiporter, and basically these are going to stop working so well. And so what you end up finding is that you're having less sodium being reabsorbed, so more of it stays out here, so you should get a nice diuretic sort of effect here. But what do you think happens to potassium levels? They're actually going to go up because you're going to find that this transporter is going to be working less actively because you have less sodium for it to transport, so more potassium stays out here on the outside. Okay, so these are why they're potassium sparing, because potassium levels are going to go up while you're losing more sodium. Okay, we'll talk about the effect of aldosterone in just a few minutes here, but this is the main thing. Again, you're going to notice this is pretty wimpy in terms of their effects as a diuretic. They're not going to be nearly as potent as a thiazide or a loop diuretic, but also think about the fact that what if I had a patient who's on a thiazide diuretic who's losing potassium? What if I added on a potassium sparing diuretic? To balance each other out, right? And so frequently you'll see a combination of the two where that way they will balance each other out. So even though you're losing potassium due to the thiazide working at the distal convoluted tubule, you'll pick up more potassium from the collecting duct. You'll hold on to more of it. And that way you balance things out and you're less likely to see hypokalemia, okay? Again, not going to be used typically by themselves, but maybe decent as an add-on. And so two we have here are going to be amiloride and triamterene. Again, very rare you see them by themselves. Frequently they're going to be added on with hydrochlorothiazide. So this would be a case where if I said the patient had a high potassium level, which drugs would be contraindicated, these might be some of them, right? Because these are only going to raise potassium. Again, same indications as the other diuretics we talked about, but again, they're pretty wimpy, only really used for their add-on effects to help keep the potassium up. Of course, be careful in patients who have hyperkalemia, as I mentioned, and be careful with other drugs that are also going to be bumping up potassium levels. And we'll talk about what those are in just a few minutes. Things like your ACE inhibitors are going to be big, notorious ones for causing that. If they're taking potassium supplements, so for instance, if they were on a loop diuretic for a long time and their doctor told them to go ahead and take a potassium supplement, and then someone added on something like amiloride without knowing that they're on that supplement, guess what? Now you can see extra increase in the potassium that could lead to issues there. Okay, so beware of that. Megaloblastic anemia is a rare side effect of triamterene. It's one kind of a unique thing there, and azotemia is a little bit more common with amiloride. So some idiosyncrasies of those two. Now, more importantly, I think is going to be this aldosterone antagonist. Yes, ma'am.
So, you were told that if you're giving someone a diuretic and you want to give them something with potassium, is that true in all cases except for this one, potassium-sparing diuretic?
Good question. So again, be careful when you hear things like always or never, because you'll find patients will prove you wrong quite frequently, right? So it's a good thing to consider is you have a patient on a diuretic, especially chronically, to consider potassium supplementation. However, think about if they have bad kidney function and they can't regulate their potassium levels very well anyway, they tend to hold on to more potassium, right? Think about if they are on a competing medication like, say, a potassium-sparing diuretic that's going to help balance that out. Basically what you got to do is like initiate the drug, kind of see where they go from there, because you're going to be monitoring labs anyway, and then you follow up and see, okay, well, do I need to add this on or not, right? So you're taking what their baseline is, seeing how the drug changes, and then figuring out what to do from there. That makes sense. So again, not every patient, sometimes it may not be the case, right? But something to at least consider. Maybe you want to add on, but not always. Anyway, so another important component here. So we mentioned the potassium-sparing diuretics work on blocking these sodium channels specifically. Well, how those sodium channels get there in the first place is due to the effects of aldosterone. Okay. Now, if you remember, we talked about glucocorticoids and mineralocorticoids. I talk about the differences between those. The mineralocorticoids work on minerals, work on salt, meaning it works on water balance, right? The main mineralocorticoid we have is aldosterone. Okay. What aldosterone normally is going to do is going to work here in the cells at the nucleus, and it's going to increase transcription of those sodium transporters, put them out here on the luminal side. So So what would happen if I blocked aldosterone receptors? You wouldn't put as many of those sodium channels there on the luminal side, and less sodium channels means less sodium gets reabsorbed, which means what happens to your potassium as well? You're going to hold on to more of it, okay? So normally what you want to think about in the collecting ducts is that there's a balance between sodium and potassium. So as you hold on to more sodium, it does so at the loss of potassium. If you decrease that reabsorption of sodium, you're going to hold on to more potassium, okay? That makes sense. So basically what you're going to find is that by using an aldosterone antagonist, you can block those sodium channels from being put out on to the luminal side here, and thus you're going to find less activity in the sodium-potassium pump, and thus you're going to hold on to more potassium on the outside here, okay? You get a mild diuretic effect. Not going to be huge like you would see with something like a loop diuretic, but again, the potassium effects are mainly what we're going to be looking for there, okay? All right, so the two drugs that fit into this category we're going to see are primarily going to be spironolactone and eplerenone. Now, we've seen spironolactone before. Where do we find that at? Probably talked about it briefly in dermatology, if I mentioned it. You're seeing someone like acne who's been on spironolactone. And some gels sometimes, maybe they're on oral supplementation there. So I'll mention why that is in just a moment. So these are the two drugs that are going to fit into this aldosterone antagonist category. So what effects are these going to have on potassium? They're also going to increase potassium levels, okay? So again, if a patient's already hyperkalemic, this is not a good drug to start for these patients, okay? So as I mentioned, they're going to bind to that steroid receptor, but they prevent the aldosterone from actually interacting with it. So they're basically these antagonists that just sit there. And so you're going to find that there's some lag time because it takes time to regulate the actual production and translocation of the sodium channels there. But you will find that you'll have decreased potassium loss, increase in sodium loss, maybe a little bit of calcium as well. So where do we use these? Well, for one, if they have a primary aldosteronism, right? So say for instance, they have like Addison's disease where they're producing too much aldosterone. Guess what those patients frequently suffer from? What electrolyte disturbance? If you're producing too much aldosterone, hypokalemia. Because again, if they have too much aldosterone, they're putting a ton of those sodium channels out. They reabsorb all that sodium, but they lose that potassium because of that, right? So if you ever look at like JFK, I think he's like a very classic case of hyperaldosteronism, Addison's disease. Basically, he was losing a lot of potassium. So by using something that blocks those receptors, you hold on to that potassium instead. So primary aldosteronism is a common reason for that. I guess it's not a common disease, but it's a common therapy for that. Hypertension, this is another good add-on medication to help get blood pressure under control from a diuretic sense. We will also use this for CHF occasionally. I'll talk more about that as we get into that section later on. And then also for edematous conditions, this can be useful, right? Especially when you're trying to balance out the effects of a loop diuretic. You get some additional diuresis, but also you get to balance out that potassium a little bit. So again, what are the adverse effects you can see? Well, certainly hyperkalemia is going to be a thing here. And this is the other thing I want to focus on here, the weak androgenic effects, okay? What this means is that for patients, and I say androgen, what does that mean? What kind of hormone is that? Testosterone, right? Or DHT, dihydrotestosterone is another more potent form of it. So when I say an androgen, that means like sort of a masculinizing hormone like testosterone, okay? So this has a weak androgenic effect. Basically, it's a partial agonist at the testosterone receptors. So that means for patients who have relatively high levels of testosterone, let's say a male patient, typical male patient, by having a partial agonist on board, what does that do to the overall androgen activity? It should lower it, right? Because you're only getting some of those receptors only being partially activated. Okay, so that means you can have more estrogenic effects in those patients, which means a common side effect from something like spironolactone is gynecomastia in male patients, right? Because overall there's less testosterone activity, more tips the balance over to estrogen, and thus you end up developing gynecomastia. You can see testicular atrophy, things like that. Okay. This is what happens in people with high resting levels of testosterone. What if you had, say, a typical female patient has low resting levels of testosterone? What do you think it would do for them? Having a partial agonist on board would raise it up, right? So now you have more activity at those androgen receptors, and what's it going to do for those female patients? It'll have masculinizing effects. So you can see things like menstrual irregularities, you can see hirsutism. So again, that has to do with the weak androgenic effects. Okay. Now when we talk about OB-GYN stuff, we'll also talk about things like oral contraceptives. We'll talk about how a lot of the progesterones can have some effect at things like aldosterone receptors and whatnot. And actually you can see that some of those can actually cause mild weight loss fluid, decreased fluid retention due to these aldosterone effects here. But the main thing I want to focus on right now is the fact that these are weak androgenic agonists. So depending on where the resting level is, this can affect it pretty significantly.
So could this potentially help someone who has an enlarged prostate?
It potentially could. I will tell you that we have other therapies that are more effective, but certainly maybe if the patient had CHF and a large prostate, maybe that would help some, certainly. But also think about if you have, say, a female patient with, say, PCOS. PCOS patients typically they have high testosterone levels, right, and they have anovulation and things like that. Sometimes spironolactone is added on board because it helps to decrease some of those androgenic activity, right? So that's actually one way you can treat PCOS potentially with spironolactone. Also think about if patients have acne, and some of that acne is being exacerbated by androgenic activity, right? We know that androgens help to increase that sebum production and things like that. This helps to lower that to some degree and can help to deal with that, right? So there's lots of different clinical indications based off this partial agonist effect. Yes, ma'am.
So just to clarify, usually in females it would cause an increase in testosterone.
Activity,
but
yeah.
Unless you like have PCOS where you already have.
You already high levels to begin with.
It will actually lower it?
Mm-hmm.
Okay.
So you have to think about what's the resting level and how does that alter that, right? So that's why I say high testosterone activity is not all male patients. Sometimes it could be female patients too, right? Yeah, yes, sir.
I was going to ask the same thing. Like, how do you know what level you know?
It's based on history, based on previous diagnoses or past medical history. All that will kind of inform you kind of where they're at, right? But you can kind of generally assume, and again, it's not the case all the time, but a typical male patient should probably have higher activity than a typical female patient, right? There are certainly exceptions to that, but that's a general rule of thumb. Okay. Any questions on that? Typically, a plurilinone is less likely to cause those effects. So, for instance, if you had a guy who was complaining of, say, enlarged breast after starting spironolactone, switching over to plurilinone might be a good option there for those patients because it's less androgenic activity. Okay. All right. Let me just finish up the diuretic section. We're pretty close to the end for this section here. So we've gone through the loop of Henle, the distal convoluted tubule, the collecting duct. Now I want to focus on the proximal convoluted tubule. And here we have the carbonic anhydrase inhibitors. Now we've actually seen this class of drugs before. Anyone remember where we saw them? Glaucoma, yes, absolutely. What do they do for glaucoma? They decrease pressure by what mechanism? Yeah, they decrease aqueous humor production, right? And it did that by regulating or dysregulating how bicarb is able to be reabsorbed across the membrane, okay? Sodium bicarb by itself, or just bicarb by itself, I should say, does not like to cross the membrane because bicarb has a positive charge on it, so it doesn't cross over. What happens, though, is you have the enzyme carbonic anhydrase, and what does that normally do? Converts bicarb into CO2 and water, right? CO2 and water can cross over pretty easy, right? And then you'll have carbonic anhydrase across that membrane that will convert it back into bicarb. So what normally happens is that you filter bicarb from the glomerulus and then try to reabsorb that, but it can't really go through the renal tubule by itself, so carbonic anhydrase will then convert it over into CO2 and water. That you can reabsorb, and then carbonic anhydrase will convert it back into bicarb, okay? What would happen if I inhibited that process? More bicarb would stay in the renal tubule, and you just do what? Pee it right out, right? So kind of keep those effects in mind there. We have 3 drugs that are going to fit into this category. Yes, ma'am. I will repeat those. I have a picture. I'll show you that, definitely. I just want to at least kind of like lay the groundwork, and then we'll expound upon it, for sure. So 3 drugs. The main one you're going to run into most commonly is going to be called acetazolamide, or Diamox. You also have dichlorphenamide, and then methazolamide are going to be the 3 main carbonic anhydrase inhibitors used as a diuretic. So here's this picture here. So imagine here's the normal state, and here's going to be the state with the carbonic anhydrase inhibitor on board. Normally what happens is you would filter the bicarb through the glomerulus. It's going to come down here. You see bicarb by itself normally cannot cross over too easily, right? What happens is that carbonic anhydrase is going to split it into CO2 and water, which can be reabsorbed relatively easily, and then carbonic anhydrase will then convert it back into bicarb, and then that can be reabsorbed into the bloodstream, okay? Well, if I interrupt that process here, you're going to find that more bicarb is stuck out here in the renal tubule, and then you just pee it right out. Okay? So what effect do you think that would have on the pH for the patient? Yes, you would decrease the serum pH for the patient because you're peeing out all your bicarb, right? What would happen to say you were looking at a urinalysis and you did pH there? It would be higher, right, because you're peeing all that bicarb, right? So you're basically alkalizing the urine, but you're acidifying the blood, okay? There's a couple cases we can use. As I mentioned, it's a pretty weak diuretic because any additional sodium or water that you're holding onto by decreasing absorption of that bicarb, the loop of Henle is going to take care of that for the most part. So you get a little bit of mild diuresis, but it's not much. However, we mentioned how it can be effective for, say, instance glaucoma, where it can decrease aqueous humor production. And some other cases you might use this include things like epilepsy. Actually, by putting the patient in a slightly more acidotic state, you increase the seizure threshold, making it more difficult to have a seizure, and so sometimes we'll do that to make sure patients will hopefully prevent seizures, right? That's one way we can do it. We'll talk more about epilepsy next semester. Also, mountain sickness. What is mountain sickness? Yeah, so say for instance, like we took a trip here and we magically transported ourselves to Colorado, right? We're in Denver, Colorado. How high is that area? Mile high city, right? So what happens to the partial pressure of oxygen at that high of altitude? Goes down pretty significantly, right? Has anyone like been to areas of high altitude that had a rapid change? You ever like try to climb a set of stairs? What happens? I was like, I knew I was out of shape, but I didn't think I was that out of shape, right? It's incredible. Exercise tolerance just goes out the window. So what's interesting is that because your hemoglobin is only set to really handle Florida amounts of oxygen, where we're pretty plentiful. When you go up into a higher altitude, less partial pressure, you're going to find that you're in a state where you're just not able to really compensate for that. So what's interesting is that initially what we can do is actually give you acetazolamide prior to going on that trip. Say if you want to go to the mountains of Peru or something like that, they would give you acetazolamide, and what that actually does is it puts you into a mildly acidotic state. And that does a couple of things. So for instance, if you increase the acidosis, what does it do to your respiratory rate? Well, you want to breathe faster in order to get rid of that, right? So you're taking in more oxygen. That's one way. And then also, you guys have heard of the oxygen desaturation curve, right? It shifts it such that you're more likely to drop off oxygen at the tissues because they're mildly acidotic as well. So basically by doing that, you're trying to stimulate this process a little bit faster such that you're able to take up more oxygen and drop it off at the tissues where it's needed, and this helps to acclimate a little bit faster to that process. You don't get the same sort of side effects from climbing the altitude very quickly. So that's another case where you might use it. And actually, it's interesting as well, these can stop or help to decrease production of CSF, which could be good if you had, say, increased intracranial pressure. It's like a head injury or something like that. It's going to actually help draw off some of that fluid there. So a couple different uses. Notice here we don't use it for hypertension, don't use it as a diuretic itself because it's pretty wimpy from those standpoints, okay? Any questions on that? Again, as we mentioned, adverse effects, metabolic acidosis, because we're peeing out all that bicarb there. You'll see some potassium depletion, and drowsiness is another pretty common side effect of that one. Yes, ma'am?
So if it's making you drowsy, is it like beneficial enough that it would give you enough energy to be able to do height?
Yeah, so I mean the drowsiness is relative, right? So imagine if you're just kind of sitting around not doing much, maybe nod off or something, right? But it's not going to be as significant as it would be as if you were taking like a Benadryl or something like that, right? That would be much more significant in terms of causing that drowsiness. So it's kind of a mild effect. Yep. Any other questions? If not, let's do a 10-minute break. We'll come back and then continue on. All right, you guys ready? Continue on. Was that 10 minutes? It was close to 10 minutes. Is it ever 10 minutes? I'm going to go ahead and get started, but I feel like that was pretty close, so we'll allow people to roll in. Anyway, so question here on the board. So when would you give it loop IV versus oral? So loop diuretic, IV versus oral. When do you think? Emergency. If it's an emergency to get rid of that fluid, what do you do, IV or oral? IV, 100%, right? When would I want to use oral? Outpatient use, 100%, right? So outpatient use, so they're going to be administering it themselves. Oral is totally fine, right? Now, what if I had a patient who's like, say, on the med surg floor, like they're coming in for, CHF exacerbation, they're, 2+ pitting edema, their lungs sound kind of junky, but otherwise they're cardiovascularly stable, IV or PO. You get rid of that fluid. If they were needing to be admitted and they were at the point where I could hear the fluid on the lungs, like I'd probably want to go IV in that situation there, right? At least to get them stabilized, get rid of that fluid, and then maybe transition them over to oral, right? If the patient was again less sick, then maybe I would go ahead and just use oral off the bat. So what's the benefits of using oral versus IV? Less risk for infection, right? So ideally you'd like to get all of your patients switched over to all oral medications so you can get rid of the IVs, right? Because IVs are a risk for infection. What other benefits? cheaper, easier to administer, right? So those are all kind of benefits from doing that. So again, that's how you might make the decision between the two there. Typically, if they're sick enough to get admitted, you probably start with IV therapy and then kind of back off depending on how they're going. Yes, ma'am.
Would you use, how long does it take for the oral to kick in?
So a little bit, maybe 30, 45 minutes before you really start to see the diuretic effect there versus like IV, how fast would it be? A couple minutes, yeah. You start to see that increase urine outflow pretty quickly there. I mean, you could even see the patient has a Foley catheter in, right? You could see it almost, right there in real time as it starts to increase that urine outflow. So it's pretty dramatic when you get to see it. So it just depends on the situation there. So, any other questions? Okay, so getting back into the actual lecture itself. So we're talking about the RAS system now, that renin-angiotensin-aldosterone system. We've kind of alluded to it already in terms of what it does. Let's get into more of the details here. So what does the renin-angiotensin system do for us? Well, it helps to regulate blood pressure, right? Typically by doing what? Increasing it or decreasing it? Usually increasing it, right? Have you covered this in your medicine courses at all yet? You will get there. You're like, maybe I remember maybe somewhat hearing about that, maybe. A little bit. Sounds familiar. Let's go with that. I'll assume you know nothing about the topic, and let's go from there. How about that? Fantastic, right? So, starting off with blood pressure regulation, you're correct. That typically will increase it, right? We'll talk about why that is in a few moments. It also will stimulate secretion of aldosterone, which we know does what for us? Reabsorbs sodium and decrease potassium, but along with sodium goes what? Water, right, which does what to our blood pressure? Also increases it, right, by getting that blood volume up. So we're going to find that not only does the renin-angiotensin system help to cause vasoconstriction, but it also helps to regulate the blood volume to increase it, to also help with that pressure, right? We're going to see that this has an effect on renal blood flow. We'll see it has an effect on sodium excretion, mainly through aldosterone. We'll see that it affects the autonomic nervous system. There's all kinds of different effects we can see with this. And we'll cover those details, what happens when you start to monkey with the system. So what normally happens is that when the kidneys detect that there's low blood volume, there's low filtration, low sodium, they will then stimulate release of renin. Okay? Renin comes from the kidneys. Renin is then going to stimulate the conversion of angiotensinogen over into angiotensin 1, okay? The primary thing we're going to be focusing on is this conversion from angiotensin 1 to angiotensin 2. You notice here, what is the enzyme that does this? Angiotensin converting enzyme, which makes sense because it converts angiotensin and it's an enzyme, right? So it's right there in the name. So normally what ACE does is it breaks down angiotensin 1 into 2, and this is the primary thing that's going to be interacting with angiotensin receptors, right? So for instance, in the adrenal cortex, it stimulates release of aldosterone. In the case of arterioles, it's going to cause vasoconstriction. So that's essentially how it's going to be working here. Another side thing to note here as well, and this is important for some of the adverse effects along with therapeutic effects of the drugs, is that ACE is also responsible for breaking down a product called bradykinin. Okay? Bradykinin also causes some vasodilation, which should help with blood pressure decreases, right? We're also going to see it's responsible for one of the big side effects that you see with ACE inhibitors, okay? Anyway, so getting into it, we're going to find that typically secretion of renin is controlled by a couple of things. One's the macula densa, right? Macula densa has those juxtaglomerular cells where they're going to be detecting sodium and blood volume and things like that. But also we have things like renal baroreceptors. It's a baroreceptor. Detect pressure, right? So they detect low pressure, guess what? They're going to release more renin. They detect low sodium in the kidneys, they're going to release more renin because it says, hey, we need more blood flow here to the kidneys. Let's try to regulate that with the renin-angiotensin system. Also, the sympathetic nervous system can also affect this as well. So as I mentioned, decreased renal perfusion means more renin release. You're going to find that, again, as that macula densa sees low sodium levels, it's going to cause more sodium or more renin to be released there, and then the sympathetic nervous system itself will then directly stimulate release of renin. Okay, which makes sense because if you're in a fight or flight response, what do you want your blood pressure to do? Probably to go up, right? So that way you can perfuse the muscles, you can run away from whatever is chasing you, right? Whether it be Halloween's coming up, maybe it's an axe murderer, maybe you're at Halloween Horror Nights. That can directly affect the renin-angiotensin system, right? Now you'll never be able to go to a theme park again without thinking about, oh wow, what's going on with my kidneys right now as I'm riding this roller coaster, right? Again, the benefits of having medical knowledge. So anyway, angiotensin 2 though is a very good vasoconstrictor. It also stimulates aldosterone secretion, as I mentioned, so that's going to help to hold on to more sodium and more water. You also find that it will cause renal vasoconstriction, and so this is another case where I'm going to be drawing my glomerulus here. And so again, imagine we have our glomerulus. Again, my poor artwork. All right, so remember this is the afferent side, this is the efferent side. So we mentioned what causes increased flow through the afferent side. Prostaglandins, right? So again, if I lost those prostaglandins due to the influence of, say, an NSAID, that goes away, that vasoconstricts, and then what happens to my GFR? It goes down because I have less blood flow coming in, right? So I pinched off the hose essentially. Now what's interesting here is that on the efferent side, you're going to find the opposite effect. So by squeezing off on the efferent side of things, what does that do to my GFR? It actually increases the pressure and increases that filtration rate, right? So it's kind of like when you put your thumb over the end of the hose, right? The pressure gets higher, and so you see a lot more water flowing through there, right? So it looks like a lot more water. My 3-year-old just figured out how she can do that, and it was a big mess. It was not great. Anywho, so by pinching off the efferent arteriole, by closing that down, you're going to find that increases GFR. So if the kidneys detect low blood volume, low perfusion, they increase renin, which increases angiotensin 2, and Ang2 is directly going to cause vasoconstriction here, okay? Now some patients, especially with chronic kidney disease, they really require that angiotensin 2 to pinch down on that efferent arteriole to keep GFR up. So another thing you'll hear about things like ACE inhibitors is they can induce kidney injury in your patients and cause kidney failure. Well, imagine why that might be. If I lose that angiotensin 2, what happens to that efferent arteriole? It dilates, you lose that pressure, that back pressure, and then what happens to GFR? It goes down, right? So that's why, similar to how NSAIDs, they say, oh, NSAIDs can cause kidney failure. Well, it's for those patients that really need those prostaglandins to keep that pressure up. For patients who are getting an ACE inhibitor or something similar, you're going to find they say, oh, that can also cause kidney failure. That's for a different purpose, but on the efferent arteriole. It's going to cause that dilation, you lose that back pressure, and GFR goes down. Okay, makes sense? So that's an important sort of mechanism there for helping to regulate GFR and helping to regulate renal perfusion. Okay. Yes, sir?
So it only vasoconstricts in the afferent?
No, it'll vasoconstrict kind of everywhere on most of the arterioles, but that's the main in terms of its effect on kidney blood flow, is affecting the efferent arteriole. Yes, ma'am. Yeah, so this is going through the renal, let me find my marker here. Yeah, so this is actually what's getting filtered and actually going through the renal tubule to get eventually either reabsorbed or excreted through the urine. Yep. Yes, ma'am. It has to do with how blood's flowing through the glomerulus, right? So afferent means it's going in, efferent means it's coming out. Yes. I always think like effervescent, like you think of a bubbles coming out, like that's, I think, efferent, kind of like that. That's how I always thought about it. Anyway. Okay. So in terms of also angiotensin 2 stimulates the sympathetic nervous system, right? We said that sympathetic activation also causes hypertension, tachycardia, etc. So these can also be affected by this. Also, you're going to find that increasing angiotensin 2 activity also increases ADH secretion. Antidiuretic hormone normally does what? It's antidiuretic, which means it's going to cause you to pee less, right? How does it do that? So it's interesting. So aldosterone, you want to think aldosterone working the collecting duct to work on sodium and water reabsorption. In the collecting duct, aldosterone, ADH, is only going to work on water reabsorption. That's the main difference. ADH has no effect on sodium directly. It only affects water reabsorption. And it does so because it actually, when it comes into interacting with the collecting duct, it actually puts aquaporin channels into that luminal side. And actually, let me just go back a couple slides here, just so I can show you the picture. So we're talking about our aldosterone antagonists. I should have done this a different way. Here we go. So imagine here you have your collecting duct. Here you're going to find the ADH will actually stimulate these water aquaporin channels to be placed in the luminal side, and that allows just for water to be reabsorbed. Okay, so that's one way it helps to get blood volume back up because you're holding on to more water, right? Remember, I've probably talked about this before. Remember I said, like, why does alcohol make you urinate so much? It actually blocks the release of ADH, centrally speaking. So that's why whenever you break the seal, so to speak, you have to urinate a bunch because ADH is being inhibited there, and you're not having as much water reabsorption in the collecting duct, thus you're producing more urine. Okay. Now, also, what does ADH do kind of centrally? Like, what kind of behaviors does it encourage? Anyone know? So if you ever get a chance and you see someone who has SIADH, You know what SIDH stands for? Syndrome of inappropriate antidiuretic hormone. So you see this sometimes in patients who have like head injuries, stroke. Sometimes will get this. So basically, they're releasing all this antidiuretic hormone, and so certainly they're going to hold on to a lot of water in the kidneys because of that. Also, what's interesting is this, behaviorally speaking, they have this thirst response because your body's detecting this. That hey, antidiuretic hormone says maybe we don't have enough blood volume here. We need to get more water in the system. So you have a very strong thirst response. Okay, it means they're going to try to get water into their system. Okay. It's really interesting if you ever get a chance to work with these patients. I remember this one lady who was in a car accident. She had a head injury and developed SIDH afterwards. And she was so thirsty that she was pleading and begging with anyone she could find to get some water. The problem is that when you have all that antidiuretic hormone, you're holding on to all that water. What does it do to the sodium? It decreases because it's diluting it, right? So the patients will develop hyponatremia along to go with that antidiuretic hormone release. So if she was to ingest any more water, what would that do even further? Cause the sodium to get even less, the more diluted out, and then she could develop CNS symptoms, seizures, etc. And so she was on water restriction, right? The doctor's order said no water for you. And so she was like, I gotta get some water. I want some Gatorade. I want anything. So she would plead with the nurses. Nurses said, I can't do it. Family members would come in. She's like, go down to the cafeteria, sneak me some Gatorade up here. She would tell her own grandma to get some water because she was so thirsty. But that was the actual therapy, was to keep her from drinking any water, right? To keep her from trying to hold on to all that extra water until that ADH kind of resolves by itself. So think about ADH causing that thirst response, right? That's going to be an important aspect of that as well. Anyway, what's also interesting is that angiotensin 2 has a strong response on causing cellular sort of remodeling, right? So say, for instance, after you have like a heart attack, right? After you cause infarction in that tissue, does it come back nice and healthy after you have a heart attack? No, right? You get remodeling that occurs there. Or say, for instance, you have chronic hypertension and your left ventricle is having to beat against that high pressure for a long time. What does muscle do when it's overtaxed? Hypertrophies, right? And it gets stiff and thick and doesn't really work all that well. That's where a lot of that remodeling is going to be due to angiotensin 2. So we're going to see that by blocking the effects of angiotensin 2, you can have big effects on, say, for instance, left ventricular remodeling. You're going to see it's going to have big effects on helping with kidney remodeling over the long term. And so this is why angiotensin receptor blockers and ACE inhibitors are going to be so effective for helping to provide longer lifespans by decreasing mortality by a lot of these ancillary effects here. We'll talk more about this as we get into it. So anyway, so overall, if you have an overactivity of the RAS system, you're going to see hypertension, you can see congestive heart failure, and because usually if you have systolic failure, what's the problem? What's failing them? The left ventricle is failing them, right? It's not functioning all that too well, and RAS is going to be an important thing that helps with that remodeling and leads to that hypertrophy and whatnot. Also, things like diabetic nephropathies tend to be caused partially due to the renin-angiotensin system, and also I mentioned that myocardial remodeling, which usually leads to things like CHF for those patients post-MI. So we're going to see that when you have an interruption in the system here, you're going to have big effects on morbidity and mortality. So this is why a lot of your patients are going to have some indication to be on an ACE inhibitor because of these really positive effects these are going to have. Okay. So what are some physiologic activities if we block that ACE enzyme? We're going to see decreased angiotensin 2 related vasoconstriction. You see less renal vasoconstriction, which can be a problem for some patients acutely. You're going to find that can cause a big decrease in their GFR, as I mentioned with that picture I drew a few minutes ago. However, you're going to find in the long run it's overall kidney protective, especially for diabetic patients. You see less aldosterone activity, you're going to see less effects from the sympathetic nervous system, you're going to see all these things here. And so what's also nice here as well is when we talked about diuretics causing reflex activation to the renin system, well guess what? That's being blunted by using these drugs here to interrupt it. So the ACE inhibitors, they're all acting exactly the same by blocking the angiotensin converting enzyme. They only differ in terms of how they get metabolized, what their half-lives are. Some of them are prodrugs, right? We mentioned prodrugs are what? They're inactive initially, but they get activated in the liver. So most of these are going to be oral agents, maybe a few that are available IV. We'll mention one example there. And then for the most part, most of them are going to get eliminated through the kidneys. So there's a lot of these drugs here because when they first started coming out, they realized these were kind of like blockbuster sort of medications because they knew that, everyone's going to need to be on that, right? Because if you look at like drug development, if you compare the people with hypertension versus the number of people who develop like MRSA, if you're a drug company, where does it make more sense? Where are you going to make more money from? Treating all the patients with hypertension, right? So there's a lot of these drugs that came to this category. What's nice though is that you can always tell an ACE inhibitor because it's always going to end with pril, right? So you have captopril, lisinopril, enalapril, benazepril, right? They all end with pril here. And they all work pretty similarly to one another, right? What's actually interesting with enalapril, as I mentioned, it's a prodrug, but the IV form, we actually give the activated form already where it bypasses the liver, so we just give enalaprilat, and that's the actual IV form. So if you ever see vasotec, that's what that is. Quinapril, ramipril, perindopril, moexapril, and perindopril. Actually, I put that one twice. I don't know why, but probably because there's so many of them I didn't even realize I put that one on there already. Go ahead.
So sorry, I'm just curious. When these drug companies are making these medications, are they kind of required to it's the same class that has to end in the same software?
No, they're not mandated to do that, but for whatever reason, I don't know if that's any kind of consensus between them, just do that. But as I mentioned, like with the, for instance, the loop diuretics, you saw there's like, furosemide, torsemide, bumetanide, and then ethacrynic acid. So sometimes you'll find ones that are pretty different. Depends on the chemical names and whatnot. Okay. So anyway, so most of the ACE inhibitors are nice because they're also good for compliance because they're only one-time daily dosing for the most part. However, some patients may require a little bit more frequent dosing, especially if you notice towards the end of the day that things start to wear off and the blood pressure starts to come back up. But you will notice that at lower doses you get a pretty steep dose response curve and increasing the blood pressure reductions. However, it tends to flatten out at a certain point. So there's no real benefit to keeping, increasing the dose past a certain point for these patients. So how are we going to use them? Well, they're going to be really good for treating hypertension. They're going to get total peripheral resistance down. They're going to be able to get systolic and diastolic pressure down by their effects on the RAS system and inhibiting the production of angiotensin II. And they'll also find that you can decrease left ventricular hypertrophy due to that elevated pressure, right? So it's going to be working mainly on the afterload side of things to help decrease the strain on the left ventricle, right? And we also like this a lot in diabetic patients because you'll find that they have kidney protective effects. When we talk about diabetes next semester, you'll see that's often a chronic complication of diabetes is the nephropathy that comes along with that, okay? So really good for those patients. And some of the test questions might actually be about something like, patient shows up, they have a history of diabetes, which one of these medications would be indicated for their hypertension? You'll say, okay, where's the ACE inhibitor at? Where's the ARB at? Because that's what I know that they need to be on for their nephropathy. Protective purposes, right? These are the things I want you to kind of key in on, like what drugs are going to be good for what kind of patient. Patient with hypertension, history of kidney stones. Maybe thiazide diuretic is good for them, right? These are little things you're going to be picking up on. They'll indicate this is a good drug for that patient, okay? Okay, other things we're going to see these used for to help with the left ventricular dysfunction for CHF. We'll certainly see it used there. Again, it's going to help with the afterload side of things. It's going to help with the remodeling. Very good from that standpoint. And we actually find that patients with CHF have fewer hospitalizations. They have fewer incidents of MI. Really good for them in terms of mortality and morbidity. And in general, if they have any degree of left ventricular dysfunction, patients should be on an ACE inhibitor. Okay. We like these post-MI because they have decreased that remodeling and you have decreased mortality. So if they have a previous MI, guess what? They should probably be on an ACE inhibitor, right? Diabetic nephropathy, as I mentioned, they will help to chronically decrease the strain on the glomerulus by decreasing that pressure there. And so it's going to be able to help with that remodeling. And again, with the kidneys, you can't really reverse disease, but you can certainly slow it down. And this is where the ACE inhibitors are going to be good for that. So side effects. Cough is going to be one of the big things you're going to see with the ACE inhibitor specifically, and a lot of that's related to bradykinin, right? We mentioned by inhibiting ACE, what does that do to bradykinin levels? They go up, right? Because they're not being broken down because that enzyme is being inhibited. So bradykinin levels are going to go up. You also end up seeing some accumulation of something called substance P in the lungs as well, which tends to be irritating, and so you'll have this dry, hacky cough that just kind of happens all the time. Now, the patient may not even notice it because they get so used to it, but who do you think is going to notice it? Yeah, whoever sleeps next to him, right? So I remember my cousin, he got started on an ACE inhibitor at one point, and his wife nearly divorced him over this cough, which necessitated him switching to a different class of medications because it is so annoying to have to deal with that cough all the time, just sleeping. Yeah, right. It was annoying, just 3 of those, right? Imagine if you had it all night long. So because of that, you're going to find it's not related to any specific agent. It has to do with the actual mechanism of the drug itself. And so in some cases, they may need to switch over to a different class of meds. We'll talk about what that is in a moment in order to avoid that. Here, because we are decreasing aldosterone secretion, guess what it does to potassium levels? Increases, right? So ACE inhibitors are going to cause an increase in potassium. This will be another one of those things where if they have hyperkalemia, not going to be a good set of drugs to put them on initially, right? To get that potassium under control. Certainly hypotension is going to be something you're going to see, and typically with older patients who maybe have less sort of hemodynamic reserve, typically the mantra for antihypertensives is to start low and go slow. So gradually titrate them up to an effective dose, right? You don't have to blast them with full dose right away. However, though, you may think about giving them, say, the first dose at nighttime when they're asleep anyway, in order to avoid them from having a lot of orthostatic hypotension, things like that. So, as I mentioned, that renal function impairment is an acute issue, but we just said that it's kidney protective, right? Especially for diabetic patients. So that's okay. So again, that's another reason to start at low dose and gradually titrate them up. You're going to mitigate that decrease in GFR initially, and as they get kind of used to it, then their kidneys will be able to regulate that. Okay. So again, just know that acutely, if you get a full dose ACE inhibitor to someone who really requires that Ang2 to keep that efferent arteriole constricted, they're going to lose that. It dilates, and then GFR goes down. But that's an acute thing. It's still okay to give them an ACE inhibitor chronically. You just got to titrate them up to it. Okay. Make sense? All right. Other side effects, a rare side effect of the ACE inhibitors, and a lot of this probably has to do with bradykinin buildup, is angioedema. So I've never seen someone with such a swollen tongue and lips as I have with someone who had true angioedema to an ACE inhibitor. Obviously, why is this a medical concern? Everything in their whole airway starting to swell up, you can lose the airway pretty quick, right? I had one patient who would come in, he had a known history of angioedema with an ACE inhibitor, but I guess he forgot or decided to take one anyway, and came in, everything was completely swollen up. We couldn't even get an endotracheal tube down, so what we end up having to do is get a fiber optic scope to actually go through the nose and actually loop a tube around that and then actually get that and get an airway. So again, it can be very dramatic for those patients there. Again, that was interesting because he was actually awake for the whole time, so we gave him some ketamine to kind of keep him like breathing and awake, and then we're able to get the nasal tube in place there. So pretty dramatic. But what's interesting too is that like some patients will manifest it very early on. Some patients may be on the drug for years before it develops. So it just depends on the situation and when they might be more susceptible to it. Okay, so beware of the angioedema. It's a life-threatening sort of complication there, but it's pretty rare. Also note that these are going to be contraindicated in pregnancy. Do not want to give ACE inhibitors to pregnant patients because you'll find that angiotensin II is really responsible for a lot of that fetal development, and so these are not going to be recommended for them. Okay. When we get into talking about OB-GYN stuff next semester, we'll talk more about management of hypertension and preeclampsia for those patients, but just know ACE inhibitors are not on the table here. Okay. Also note, NSAIDs can decrease the activity of ACE inhibitors, mainly by the effects on the kidneys there. Because we mentioned NSAIDs are going to have a negative effect on GFR in the kidneys, so just be aware that it can have some interactions with that, kind of decrease the antihypertensive effects. So if the patient was having, say, that annoying cough, or they couldn't receive ACE inhibitors for one reason or another, you could also, instead of inhibiting the conversion from angiotensin 1 to 2, you could just get down to the receptor itself and block that. And so that's where we have our ARBs, or angiotensin receptor blockers. I'll show you the list here, and they have a pretty easy naming convention as well. You'll find that AT2 is primarily going to be expressed during like fetal development, so we don't care about that one, but this AT1 is certainly the one we care most about in terms of hypertension and management of that. So basically, we're going to have drugs that instead of working on this conversion here, you're going to find that it just blocks this AT1 receptor. So why do you think this gets rid of that cough? Because bradykinin is going to be left unaffected, or it's going to still be able to be broken down. Okay, so because of that, by using the ARB, you get rid of that cough, and that's the biggest reason why you switch over from ACE inhibitors to ARBs for most patients. Okay, both are pretty equally effective in terms of blood pressure management, right? In terms of cardiac remodeling for CHF and diabetic nephropathies, but if they have that annoying cough, that's a good reason to switch them from one to the other. And again, very similar activity. Guidelines will say, hey, start off with ACE inhibitor. If that's not going to work, ARBs are perfectly valid in terms of their activity. Yes, ma'am.
Why are ARBs not first line then, if the cough is such a good thing?
Well, because the bradykinin is actually somewhat beneficial because it is vasodilatory, so you may get some additional blood pressure effects out of that bradykinin. So, and plus, the ACE inhibitors have been around for longer and they're better studied. So the studies have more evidence to show that, yeah, these are going to have good effects on mortality. You know, ARBs certainly have some evidence, but it just maybe not as much. And the thing you'll find, especially with in terms of medical literature, is that really common disease states, they have really good literature to back it up. So for instance, we mentioned how many people have hypertension? A lot of people. So you can do really big studies and thousands and thousands of people and have really good evidence to show that, hey, this drug works, this one doesn't, right? Versus if it's something like, something that only affects pregnant patients, can you do those kind of studies very easily? No, because they're a protected class, right? For toxicology, can I poison a bunch of people and give them these people this treatment and these people this treatment? No, right? Sometimes I wish I could, right? So it'd be kind of good. Like, I'm going to bite you guys with a coral snake and give you anti-venom. I'm going to bite you guys with this coral snake and get no anti-venom. We'll see what happens. You can't do that kind of study, right? It's just not ethically viable. So you tend to find that depending on the discipline, you may have more or less evidence to back up what you're doing, right?
And then going off of that, so then how do they know not to get us pregnant? It's just like if you think of the process, you're like, that would be good for female stuff, just not for that.
Well, how do you think we would know that? Anyone know?
Was given.
So that's
So yeah, so either it was given at some point they noticed the issue. More likely than not, though, they probably gave it to, what do they do before they get into human studies? Animal studies, right? They probably did animal study. Poor animals, I know, but they sacrifice themselves for human benefit. Again, maybe in the mouse overrise or upheaval, they'll come and give us all the medications, test it on us first. Who knows? But they probably noticed in animal studies that there was negative harm on the fetus, and so they can extrapolate that to say, hey, there are probably going to be negative effects on human fetuses as well, right? So anyway, you're going to find that for the most part, these work interchangeably. Again, they do not have the same activity on bradykinin, so maybe a little less effective in terms of blood pressure management. But also note here that while the ACE inhibitors are mainly renally eliminated, the ARBs tend to go both through the renal and the bile, so some liver elimination there. So you can always tell an ARB because it's going to end with sartan. So you're going to have losartan, olmesartan, candesartan. This is another group of kind of blockbuster medications when they came out, so everyone wanted to get on board with their own version of an ARB, which is why there are so many of them. Now, has anyone heard of anything with the ARBs in the news as of late, in the past couple months? You don't watch news or keep up with anything? No time? You act like you're in school or something like that, some kind of graduate program where they combine like 4 years of like medical education into 2. It's crazy. What'd you hear? Not that one so much. They probably did go in back order. It was a recall on them. You know why?
They found your glucosamine impurities?
Yeah, so there was, I think it was valsartan specifically, there was actually some contaminants that were in the actual due to the production. So someone watches the news. Just kidding. Yeah, so it actually had some impurities in it that, due to the production of it, they actually can cause cancer, essentially, right? So there's carcinogens. And so they had to basically have to do a big recall. So all these patients who were taking, say, valsartan, they had to get it off of that and then switch it over to something else. So as a provider, would that be a big deal to you? Why? Yes, you might have given your patient cancer potentially, right? So there's a low risk that could have happened. But what else do you have to do, just logistically speaking? You're going to get all those patients you might have started on that drug. You now have to switch them over. So the pharmacies are going to be calling you, patients are going to be calling you, freaking out. You got to switch them all over to a new medication. So it's a huge problem for the pharmacies, for the prescribers. Big debacle, right? So, but again, it's one of those things where sometimes you don't know it until it's already on the market, and they test them and find that impurity there. So that's a big issue. So anyway, so what are we going to use these for? Hypertension, just like we did for the ACE inhibitors. You're going to use them for LV dysfunction. You're going to use them for diabetic nephropathy. All the same indications as you would see for an ACE inhibitor. So no changes there. They're going to have the same side effects, right? So hyperkalemia, hypotension, etc. Still not going to be used for pregnancy. Now, what do you think about the risk for angioedema with an ARB versus an ACE inhibitor? Probably going to be less, right? Because again, you have less of that bradykinin buildup. It doesn't mean that's impossible, but there is less risk.
Why is it not second and third trimester? What about first trimester? It's like
I probably still wouldn't use it in the first trimester either, right? So
that's like the most critical time.
they probably find there's more dramatic effects. Maybe there's more expression of AT2 receptors during that period of fetal development. I wouldn't use it. You just don't use them in any pregnant patients there. Yeah. But however, does every person who becomes pregnant know that they're pregnant immediately? No. Some people can go almost the entire way without knowing. There's whole TV shows about that, right? So that's the thing. So again, as soon as you recognize that they're pregnant, then you'd want to, eliminate the exposure and get them onto something else to manage whatever chronic conditions they have, right? So again, that can be a big issue there for sure. Because again, of course, the patient who's taking the drugs and then they find out they're pregnant, of course, what happens? They feel super guilty. So like mommy guilt's a big issue with a lot of that. They're like, oh, what did I do to my baby? And it's like, we have no idea, It's impossible to know what the outcomes could be. So anyway, again, when you're using for these patients, again, start low, go slow. Especially the older the patients are, the less hemodynamic reserve they have. But note here, lower risk of angioedema, no risk for cough for the most part due to the bradykinin effects, okay, or lack of bradykinin effects. Okay. Any questions on angiotensin converting enzyme inhibitors, ARBs? All right. So let's talk about calcium, right? particularly calcium channel blockers. So we have a lot of different types of calcium channels in the body. I want to focus on the L-type calcium channel. You're going to find that these are really predominant both on the arterioles. You're also going to find that it's pretty predominant in the heart, mainly on the AV nodal conduction. Okay, SA node, AV node. Primarily, we're going to find calcium channels are really important there. Now, have you covered anything about cardiac conduction cycles? Okay, so you have covered that. Very good. So, for instance, I just like to check. I'm trying to figure out where you guys are at, right? So if you remember with the nodal tissue, if you're looking at how the actual conduction happens, so let's say you have your nodal tissue there. Normally you're going to see, does it have like a really flat sort of response in terms of like electronegativity? No, right? Because remember, if you're looking like your typical like myocardial tissue, you see it kind of stays at a flat resting membrane potential, then it like spikes up, and it kind of dips down, has a plateau, and then it repolarizes, right? How about your nodal tissue? How does it differ? So what? Well, normally what happens is they're kind of leaky to sodium, right? So you're going to find they kind of have this like natural gradual increase, and then once they hit that threshold, what happens? They have an action potential, right? So you have this big spike in, and then it kind of comes back down. That's what triggers off the whole heart, the beat, right? And so what you're finding is this big increase here is actually due to calcium, okay? So what you're going to find is by blocking calcium, what do you think it might do to heart rate? Slow it down. Very good. So the calcium channel blockers, and some specific ones we'll talk about, are going to be good at slowing down the heart rate. They'll help to decrease contractility too, we're going to see to some degree. And then also on the smooth muscle of the vascular side of things, on the arterioles, this is also going to help to prevent calcium from coming into the cells. And if you have less calcium, what does that do to smooth muscle? Because normally calcium is needed for what to happen? Yeah, for contraction to happen. So if I block calcium from coming in, guess what happens? Less contraction, you get relaxation, okay? So you're going to find that these drugs, depending on the class that we're looking at, are going to be good at helping to decrease heart rate, decreasing contractility, and they're going to be really good at helping to relax that vascular endothelial muscle, right? Smooth muscle there. So they're going to be good for blood pressure management. Again, here's another picture just kind of showing you that. Remember looking at the SA node and the AV node. Again, those are leaky cells because that's how they have the automaticity, right? So they have some degree of inward leak of sodium, and then once they get to a certain point, that's where they open up and allow calcium to come in and trigger off the action potential that eventually leads to the atrial and ventricular contractions, right? But anyway, and again, I don't know why I drew that out because I have a picture here just showing you the exact same thing, but looking at this, you can see that this calcium influx here is what's going to cause the actual contraction to occur. So if I block calcium influx, this is going to lead to decreased automaticity, decreased heart rate. Now, what causes this plateau effect here when I'm looking at, say a ventricular myocyte contracting? Calcium coming into the cell, right? This is calcium coming in that causes the plateau. So what would happen if I decrease the amount of calcium coming in? You get less contractions, get shorter. It's going to cause less calcium coming in to release less calcium from that sarcoplasmic reticulum. And guess what? The force of contraction does what? Goes down, right? Less calcium in means less contraction, meaning the force of contraction, contractility goes down, okay? So when I say something is has a negative effect on the speed of the heart rate, what do you call that? A negative something trope? You heard of this term? So if I say like a negative chronotrope, you ever heard that term before? So negative chronotrope means it slows down the rate of the heart. And I say it decreases the contractility, I'm going to call that a negative inotrope. Okay? So negative chronotrope, and it's a negative inotrope by blocking the calcium influx. Yes. So if I say chrono, think chrono time, right? I was thinking chrono trigger because I was a nerd, played video games as a kid. But think chrono time, decreasing the automaticity of the SA and the AV node by decreasing the heart rate. That's a negative chronotrope. Okay, slowing down heart rate. If it decreases the contractility of the heart, your ventricles are not contracting as hard. It's called a negative inotrope, and it's usually related to metals, ions, getting into the heart cell. In this case here, the calcium is being inhibited from coming in. So less calcium comes in, less contraction occurs, thus the force of the contraction goes down. Everyone with me? Okay, this will become more apparent as we go on. Yes, ma'am.
So, if you give this to somebody that had a really low heart rate, would that help?
Potentially. I mean, yeah, we have patients overdose on these drugs all the time, right? So they can come in with the heart rate in the 30s. They're not perfusing very well. The blood pressure's in the tank. Yeah, calcium channel blocker overdose can be.
Is that common?
It can be common. It depends on. Sometimes it's inadvertent. Sometimes it's intentional. They can be pretty nasty. In terms of like where I grade like toxic exposures. You know, like I'll talk about like aspirin being pretty high up on the list. You know, tricyclic antidepressants being high on the list. Calcium channel blockers is pretty high up there. Yeah, I get really worried when I hear someone overdose on a bunch of that stuff.
So would you not use like calcium channel blockers and beta blockers at the same time?
Mm-hmm. Yeah, we'll talk about that specifically. Yep, 100%.
These like contraindicated athletes then, they have like already slow heart rate.
It depends on what you're using it for, right? So we'll talk about different clinical indications. And again, not all the calcium channel blockers are going to work specifically on the heart. We'll talk about the delineations of that in just a few moments here. But yeah, if someone already had resting bradycardia, you know, usually if you have someone like an athlete like that, like there's not a lot of indication to use calcium channel blocker in the first place. There may be like someone who has like variant angina, like Prince metal angina or something like that. Maybe you might use the calcium channel blocker, but we'll talk about those clinical situations coming up. Yes, ma'am.
You say that it will decrease the force of the contraction. How does that happen if it's hitting the threshold?
So yeah, so if you're looking at these fast response cells, right? So again, normally what triggers off this action potential? It's usually because they have a signal coming in, right? So they sit at a resting membrane potential. Once an action potential comes and triggers them off, that opens up sodium channels, and that sets off the whole contraction, right? Sets off the whole process. So what ends up happening is when you decrease the amount of calcium coming in, that even though the action potential is occurring, right, you're also decreasing the overall amount of calcium coming in. So the action potential occurs, but you're going to find that the overall calcium decreases, and that's that force of contraction. Because again, if you look into it, and we'll talk about this probably later at some point, but the calcium coming into the cell isn't what actually causes all that contraction. It's when the calcium stimulates the sarcoplasmic reticulum to release more calcium, and that's what triggers off a lot of the actin and myosin binding together, and it's when you get the cross-links happening there, right? We'll see more of this. All right, maybe I'll do like a little short review of that next time we meet. No, I'm just saying, but I can bring that in, right? So we can make sure we're all on the same page. Well, I think we'll have some more graphs and stuff that will show that in just a few minutes here. Actually, I have a picture right here that shows exactly what I'm talking about. So imagine you have a cardiac cell, right? And so here we have the actual excitation phase. So say the SA node is fired off, that's triggered off the AV node, and now my ventricular cells are going to be receiving that action potential, which is stimulating a contraction, right? So normally what happens is once that sodium channels open up, you cause that big spike in electric potential. You're going to then find calcium channels open up. Calcium channels will then allow for calcium to come in. Calcium stimulates the sarcoplasmic reticulum to release calcium, and then guess what happens? The sarcomeres then contract together, and then you get the actual ventricles contracting, right? You know, all that's happening in concert based off of their, the actual conduction pathway. So normally what happens though is that once you close the calcium channels, then you're going to find all that calcium gets sucked back up into the sarcoplasmic reticulum, and then the whole cycle resets itself. So what would happen if you didn't ever reset that calcium? It would stay contracted, right? And then that's not good for your heart. You know, it'd just be a stone at that point, right? It wouldn't really do much. So basically what you're seeing there is that by decreasing the amount of calcium coming in, you're going to be decreasing the overall amount of calcium coming out of the sarcoplasmic reticulum. You get less contraction. That's why it's a negative inotrope, because the overall force of contraction is diminished. Okay? All right. Here's what it looks like on the arterial side when you're actually decreasing contraction of these arterial smooth muscle. Basically, we know that smooth muscle works a little bit different than skeletal or myocardial muscle, but here we find that smooth muscle tends to be very kind of slow in contractions. It typically is a lot longer in contraction. Here it's okay if there's a lot of calcium around, because they usually kind of set a certain point of contraction. They'll stay like that for a while. But by blocking calcium influx here, you have less calcium coming out of that sarcoplasmic reticulum, and thus you're going to get less contraction of the actin and the myosin together, and that will allow the arterioles to relax. Blood pressure will come down, right? Because the diameter of the vessels will go up, there's less pressure, blood pressure comes down, okay? We'll see based on which ones we're talking about with calcium channel blockers. Some of them only work just on the vasculature, so they're really good at lowering blood pressure. Some of them are better at working on both the heart and the blood vessels, okay? We'll see there's a bit of a balance between those two there, okay? So again, at therapeutic doses, we're going to find that calcium channel blockers aren't really good for venous tone, so they don't really do anything for preload, right? You guys are familiar with preload? The amount of volume getting back to the heart, but they are really good at decreasing afterload, or with the pressure the heart's having to pump against, okay? And again, based off of the type of calcium channel blocker we're looking at, we're going to find some that have a good balance between the heart effects and the arteriolar effects. Some of them are only going to mainly work on the arteries themselves. Okay, so again, they have a degree of selectivity based off which ones we're talking about. And so when we get into it, we're going to find that we'll have two delineations here. We're going to have non-dihydropyridines, and then we're going to have our dihydropyridines. That's kind of how we're going to break those two down. Basically, and this is what you need to know, is that a non-dihydropyridine, we have two drugs that fit into that category, are going to have strong effects on the heart and on the vasculature. The dihydropyridines are only going to work on the vasculature. They don't have any direct effects on the heart. Okay? Kind of keep that delineation down because I don't think we're having time to get through all of these, but we'll talk about them probably next time when we get back into it. So kind of keep in mind how the calcium is going to be working here. Next time we meet, we'll actually get into how we can regulate that and how we can use that to our benefits for these different therapeutic purposes. Do you have any questions so far? So non-dihydropyridines are going to work both on the heart and the vasculature. There's only two drugs in that category. And then we'll have the dihydropyridines, or DHPs. They work on primarily just the vasculature. Okay. So I'll leave you on a cliffhanger, so that way you're all excited to come back next week and continue on talking about this stuff, right? Right? Maybe. Okay. Any questions I can answer for you? Let me check the board. Okay, if calcium channel blocker does not have effect on preload but decreases the afterload, would the rest of the volume be backing up into the right heart or lungs? No. So basically what happens is, like, normally your venous side is, those are the capacitance vessels, right? So they can hold on to a lot of volume. If you have too much fluid on board, that's where you can end up seeing things like edema form, pulmonary edema, things like that. Typically, though, you're going to find that the calcium channel blockers don't have, they can cause some backup, especially in the periphery. So, like, for instance, you can see some edema that develops, say, in the distal extremities. However, you won't really see that cause an effect on the lungs necessarily. So we'll talk more about that as we get into them, so kind of hang on to that question. Any other questions? If nothing else, I will see you guys next time. Oh, yes, ma'am. Is it next week? Oh, I think your exam's in 2 weeks. Yeah, 2 weeks away. Yeah, so they probably will be on your exam in 2 weeks. Huh? The exam next week? I don't control your exam schedules, unfortunately, so now we're going to keep it where it's at.
So the exam will cover everything from coma beds to...
Whenever we finish up next week, that'll be the exam material.
Yeah, but starting at coma beds.
I think that's whatever we started with last. Yeah, it sounds about right. Yep. Yes, sir. There'll be some more coming up. Yeah, cardio is kind of a big topic, as it turns out. All right, I'll see you guys next time.